Shahrani is a close friend of mine. 17 years ago, I introduced Dayel in one of the symposia in Riyadh, and he was presenting in the same session with a professor coming from Boston in the US. And they called Dayel our distinguished speaker. But this time and he was only maybe 5 years after his fellowship training. So this time I really mean it. Dayel is a distinguished speaker. He is a consultant pediatric infectious disease at King Fahd Specialist Hospital, King Fahd Medical City in Riyadh. And Dayel gonna speak about otitis media in the era of short is better. Dayel, the podium is yours.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I would like to thank the organizing committee for the invitation. Thank you, Dr. Faisal, Dr. Abdul Qadir, for your moderation for this sessions. And thank you very much for your remembering that stories. Back to basic. I think today we are back to basic. Dr. Abu Jawad gave basic of invasive group A strep. I'm also going to give some basic because this is a very important talk, and if we are going at the end to get some benefit, it will stress in two important points that probably the new technology will not replace this, which is the clinical diagnosis of otitis media. Although we hear a lot about otitis media, but when it comes to the diagnosis, sometimes we are, as a physician, we may not really be that. We need some probably more and more practice and teaching also our junior colleagues for the importance of the clinical part. And I will elaborate a little bit about the new, probably it's some changes of the management. So this is kind of objectives that we are going to go over it quickly. Just a reminder of the ear structure. This is the ear as the external, the middle ear, the inner ear. And this is remind you with the bones of the ear bones, the eardrums, and also the Eustachian tubes, because very important, the Eustachian tubes, if you have anatomical issues, that is the usual in less than 2 years, or if you have a kind of obstructions, that is really a major issues of collecting more fluids on the middle ear, and this is one of the pathophysiology issues that you will get the infection there. So acute otitis media is the second most common diagnosis after upper respiratory infection in children. So just imagine, it's really a huge, the volume is huge of otitis media. And it is the most common cause for antimicrobial treatment in young children, accounting for 56% of the antimicrobial prescription for children aged 3 to 36 months and 40% of antimicrobial prescription for children 3 to 6 years. So there is also as a consumptions of antimicrobial therapy is there. The epidemiology of acute otitis media has international and regional variants and has been impacted by both pneumococcal vaccine and the COVID pandemic. And we know that since the introduction of the pneumococcal vaccine, the Brepner in 2000, then followed later on by the pneumococcal vaccine serotype 13s, that we have pneumococcal, at least invasive disease and common infection have been declined, either pneumonia, bacteremia, meningitis, as well as otitis media. So, but still, we know that there are several types of serotypes of pneumococcal, and that's why still pneumococcal is a major impact. And this is also an important figure for us to remember as pediatrician, that around 50% of children will have at least one episode of acute otitis media before 2 years of age. And around 80% they will have by 3 years. So it's really quite common issues. It's a quite common problems. We also know that there are some social issues that they may not have children who are probably in limited resources country. They may not have access to care for the diagnosis, for the management of acute otitis media. So they could, those group of patients, they could really have more complicated issues related to the otitis media, which is simple if it diagnosed early, but if it stayed, you could have mastoiditis, you could have intracranial extensions of the infection, brain abscesses, it's a huge complication that can be prevented if there is an appropriate diagnosis and appropriate management to start with. Okay. So what are the factors that contribute to the acute inflammatory cycle? Bacterial persistent is a very important part. Viral infection, and that most of the time is the trigger. So you could have a viral infection at the beginning followed by the acute otitis bacterial, because our talk is really here concentrated more on the bacterial, because this is the one we could do management for this. Allergic rhinitis, this is all predisposing and triggering factor. Recent or current upper respiratory tract infections, anatomic variations and abnormality, which set up the genesis of the acute otitis media. I mentioned earlier about the Eustachian tube, because it's very important from anatomical point of view. And it is really important in equalizing the pressures. So that's why it's quite common you have the infection less than 2 years, because of the anatomical issues related to the Eustachian tubes. When there is an obstruction of the Eustachian tubes, you will have more of otitis media. In young children under 2 years of age, as we have mentioned, the Eustachian tube is less effective in these function of equalizing pressures, because it is more horizontal from anatomical point of view. So it will lead to a slower drainage of the secretion and allow more transmission of pathogens into the middle ears. Okay, so what about the etiology? That most of the etiology, as we know, is viruses can cause otitis media, bacteria, or all associated with acute otitis media. When we concentrate about the bacterial part, because this is probably our cornerstone of our talk today, strep pneumo is responsible for more than half of all the cases, joined by Haemophilus influenza and Moraxella catarrhalis. But Haemophilus influenza, especially type B, and strep pneumo, luckily enough, we have vaccine, but there have been some decline, but still it's a major cause of otitis media. There have been an impact of vaccination, so there have been some change on the epidemiology. For example, this is one of the studies that reflect strep pneumo accounted for 40 to 45 of acute otitis media, with Haemophilus influenza 25 to 30, Moraxella catarrhalis 50 to 20, and strep pyogenes 3 to 5. That was in 1999, but in 2017, see the drop of the otitis strep pneumo. It's dropped down to 15 to 25, and luckily enough, because of our effective vaccination. And this is another message of how could we boost as well our vaccination and stress on this part. Also, there have been a decrease in penicillin-resistant strep pneumo. This is one of the probably most important talk in or stressing the talk of the diagnosis, because we know the diagnosis is really clinical, and that means that we need to every time put ourselves, are we really diagnosing otitis media, or we missed otitis media, especially in small kids, when there are some obstruction as well on the external ear, and we did not see the drum very well. There have been several, I'm sure that every pediatrician faced these challenges. So the diagnosis of the acute thalassemia rests on the visualization of the tympanic membrane and the clinician competence. And it's really good. I'm not sure how many of you have really lately got one of a resident or medical student or intern, and he show him the drum and he show them. I think this is an area of improvement. This is an area of all of us for improvement, to make sure and to stress on this, especially when they have clinic rotation during their outpatient rotation. So the diagnostic criteria that we are going to mention is very important, and the technique of the diagnosis, the clinical diagnosis of otitis media is important, because it's important for the diagnosis itself, and it's important for the management, and important for avoiding the complications of those cases. We mentioned initially that there have been a lot of antibiotic use because of possible, you just see redness and they said, well, this is otitis. So redness does not indicate otitis media. So you have some criteria that we are going to mention. This is a remind all of the basic of the drum of the tympanic membrane. As you know, there is an anterior part and there is a posterior part. So in the anterior part, there is also the superior part of the drum and the inferior part or inferior quadrant. And on the posterior part, there is also a superior quadrant and inferior quadrant. So it's a transparent, and if we have also young colleagues here, especially if we have resident, they need to be familiar with examining the ears and to know the structures. Probably even if they are examining an adult, because if they examine an adult, it will be easier for them to examine in pediatric patients. So the diagnosis depend on the bulging. So you need to have bulging of the tympanic membrane. You need to have decreased mobility, and that's why you need to have a pneumatic otoscope. So the usual otoscope may not be enough. So you need to have a pneumatic otoscope that you will have the mobility, to see the mobility of the tympanic membrane. And you need also to check the if there is a purulent or turbid fluid behind the membrane, suggestive of bacterial infections. This is a kind of tympanic membrane in a patient with acute otitis media. See how it's really bulged. It's also red. There is fluid after the tympanic membrane, and also most likely there have been a tympanic movement resistant in this case. This is another patient who has otitis media with effusion, and this is also a kind of differentiation. So the effusion is not really the core discussion today or the presentations, because otitis with effusion, probably it needs another session and another discussions. But this is a kind of diagnosis that you need really to know, are you dealing with really acute otitis media or it's an effusion, because the effusion sometimes need prolonged observations and so on. So once the examiner can see the anatomy, the examiner should take note of the various characteristics of the tympanic membrane, including the position of the tympanic membrane, the color, the presence of the bony landmarks, translucency of the tympanic membrane, and if there is any discharge. So just remind yourself with every time you see, did you see really the drum, what position or quadrant you are looking for? Did you see the bone? Is there any fluid after or behind the tympanic membrane? And if there is any perforation or any discharge. This is kind of probably some practice in certain areas that they have, they call it scope. They put a checklist on the otoscope. They make that stethoscope is an important part. So they put, for example, they discuss with the caregiver. They look for the equipment and they check it. They look for if there is a sermon, they remove it. And what did they see? And at the end, if you see her, they put their diagnosis on that part. So, and did they examine with a pneumatic otoscope or with just regular otoscope? So this is a good, especially colleagues who was working on the primary healthcare. It's good to remind yourself what did you really look for in the ear, and it's really some structured way of reaching the diagnosis. Okay, so the second part will go quickly over our management with, so we have two types of management. Management without antimicrobial therapy and management with antimicrobial therapy. There are some patients with acute otitis media can be safely managed without antimicrobial therapy. The natural history of the condition is such that the pain and the discomfort will resolve after the first few days, and the use of antibiotic may result just only in 1 day less of the symptoms. This is what they call the safety net antibiotic prescription.
Dr. Dayel, 5 minutes on.
Sure. So this is the criteria for such cases. Older children with no, and this is, we are going to summarize it also on other slides because we'll concentrate on this. Older children with non-severe acute otitis media. And non-severe here mean mild otalgia for less than 48 hours and temperature of less than 38.5. This is the definition of non-severe. No other bacterial infection, non-toxic, and these children can be followed closely without use of antimicrobial therapy. So this is a group of patients that you may not use antibiotics in those patients. So what the most important part in those patients is controlling the pain, recognizing that the acute otalgia may resolve only after the first 48 hours. Appropriate non-prescription analgesic, especially oral paracetamol or ibuprofen can be used to treat otalgia. Some people using alternative paracetamol in one time and ibuprofen in another time, but this is not recommended because you could mix the doses, and this is not really recommended. Aspirin, as you know, it's not recommended to relieve the pain on those cases. Otic drops, make sure if you are going to use otic drops that the drum is not perforated, because if it is perforated, it's contraindicated in those cases. And you need also a shared decision with the family, especially if they decide in this part, if there is no improvement in 48 hours, if they are getting more sick, more fever, more otalgia, pain, is to come back to the hospital. What about the second part, which is with the antimicrobial therapy? So the American Academy of Pediatrics recommend antibiotic therapy for bilateral acute otitis media in children aged 6 to 23 months, even if they do not have severe signs. We have, this is the indication. So for patient with severe symptoms, moderate, severe otalgia or fever more than 39, or those of age less than 2 years, those type of patients, they need treatment. Those less than 2 years, severe, they need treatment. Okay, what are the treatment? The treatment depend on the age. Less than 2 years, you need 10 days treatment. If more than 2 to 5, you need 7 days. More than 5, you need 5 days. So it's very simple. 10, 7, 5. 10, 7, 5. Less than 2 years, 10 days. More than 2 years to 5 years, 7 days. And more than 5 days, 5 years, 5 days. So this is the current recommendation of the American Academy of Pediatrics. Still, amoxicillin or penicillin is the drug of choice, provided that he did not receive amoxicillin the last 30 days, has a concurrent purulent conjunctivitis, because if you have this, it indicates that probably he has some Haemophilus influenza, which may not be covered by amoxicillin, and it can be a beta-lactamase producers. And if he has a history of current acute otitis media, so amoxicillin may not be the right choice. Okay, looking also put in consideration your local antibiogram. We are, I think this was also published before, we are looking for improvement in the strep pneumo susceptibility locally, and we published that data. Macrolides are not indicated in the treatment of acute hepatitis media unless you have no other choices. This is the Red Book recommendation, probably summarize what we have mentioned before. So this is the common organisms, strep, influenza, and Moraxella catarrhalis, and amoxicillin clavulanic acid. And this is also the duration that we have mentioned, less than 2 years, and 2 to 5, and more than 7. So complications, mention some of the complications.
Dr. Dayel, the time is over.
Okay, خلاص, then. So stressing about the breast milk again. In conclusion, so the diagnostic criteria for acute hepatitis media require the presence of bulging tympanic membrane, decreased mobility of the tympanic membrane with an erythematous color or evidence of purulent turbid middle ear. The presence of fever, just only fever, and erythematous TM alone is not diagnostic of acute hepatitis media. This is a strong recommendation. Competency in pediatric ear exam, which includes the general approach, visualization, tympanic membrane, pneumatic otoscope, and ceramion removal, is critical for the appropriate diagnosis. This is a strong recommendation. The management of acute hepatitis media in children include pain management and other supportive care, and wait and see approach. This is a moderate recommendation. The first line, we are all agree on penicillin unless there is allergy or something. So this is also a strong recommendation. And engaging the parents, this is also a moderate recommendation, using antipyretics and others. And thank you very much.
Thank you, Dr. Dayel, for this excellent presentation.